Good afternoon. Sorry, we're a few minutes late. A little technical glitch. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. As promised, we are here with Dr. Raajit Rampal from Memorial Sloan Kettering in New York, who is going to answer some of your questions about symptom management. And one of the big things we wanted to talk to you about today, Raajit, was, over all these years, and that now we have 4 treatment options and many other drugs in the pipeline. Excuse me. How are symptoms being managed generally?
Well, this is a complex thing. Well, number one, first, thanks for having me, and I'm glad to be here to talk and answer questions. It's a complicated thing, right? And I think one of the things that we always have to think about, right, are the symptoms that someone is having related to their MPN or not? And that's a hard thing to figure out in many cases, right? Because not everything is necessarily related to MPN. I think we always have to remember that, patients have other conditions, they have, life stresses, all of those things contribute to symptoms. I think, the one that is the most common and the most perplexing is fatigue. Right.
Yeah.
And what I always say to patients is fatigue is always multifactorial. There's always more than one thing that's contributing to fatigue. And even if you look at, patients who don't have MPN, right, patients who are just seeing their primary care physician, the number one complaint is fatigue, right? So I think it's always important that the first question we take a step back and ask is how much of this is due to the MPN? And some symptoms, it's just absolutely obvious it's related to the MPN. And then we think about what do you do for those types of symptoms. And others, it's a little bit more difficult to figure out, what is what. In terms of, how we think about managing it, right? We always have to think about this in a multimodal way, meaning that JAK inhibitors are great, right? And they absolutely help patients with symptoms. But I'm very much of the mindset that we shouldn't always take the approach or the stance that take this pill and everything will be better, because I just don't think that's true, right? I think that the certain symptoms we know the drugs can work on, and there's biological reasons for that, but there are other symptoms that don't respond, and we see this in patients who are on a JAK inhibitor and they just don't get relief of their symptoms. Fatigue being one of the most common things that we see that just aren't getting better, and then we have to ask why, and we've got to think about what are the other tools that we have in our toolbox. And I think there are other things, and some of that has to do more with simple things like making sure somebody's sleep hygiene is okay. Are people sleeping correctly? Are they getting enough sleep? Are there other factors involved here? Does someone's thyroid functioning properly? Is it some other reason? And then other interventions that I think can be helpful. We know, at least from other studies in cancer in general, exercise is something that does help people feel better. People with even advanced types of cancers, exercise can be a helpful component to help people. And then, there are other types of medications, things like stimulants. So there is a, concept of cancer-related fatigue, and that is something for which there are stimulants that can be useful. So I think the difficult question that you ask gives a difficult answer, which is we always have to take a step back and try to think about what are we trying to treat and how do we best treat it.
Great answer. Absolutely great. We just hosted the 10th annual Women in MPN conference in New York. And with your female patients, for years we've been hearing night sweats and brain fog. And, many cancer patients have brain fog, no question about it, not just MPN patients, but anyone that is having, therapy typically will have some brain fog. But there were other symptoms that came up that really are very similar to menopause or perimenopause. And so how do you delineate with your female patients what is happening with them? Is it their MPN, or is it, the time in their life? How do you delineate that?
Yeah, no, that's a difficult one too, right? And I think that, to some degree, the two things I kind of look for are the time of onset and sort of the cadence and then the duration of the symptoms. Meaning that oftentimes the careful history will give me most of the answer, right? If these types of symptoms had their onset and they've been kind of stable since the onset of menopause, okay, fine, this is probably related. Sometimes, for example, I'll meet a new patient, I'll ask, are you having night sweats? The patient will say yes, and then she'll say, but I've been having them for 20 years. Okay, fine. That is probably not related, right? But sometimes symptoms get worse, like night sweats, right? And that can be because of the
Yeah.
MPN. And that's where things get a little bit more difficult to understand. And sometimes you don't know the answer until you try an intervention to see if it makes it better, right? So
Mhm.
so it sometimes can be, diced apart by the history you're getting from somebody, but sometimes an intervention will be the thing that actually tells you what's what.
And as we all know, MPNs are very heterogeneous and everybody has very similar symptoms. And then there will be patients that have very different symptoms or none.
Mhm.
And I know you probably have seen many of all of the different kinds of things that go on. So let me ask one of the questions here, which is kind of a segue from what we're just talking about. This person would like to have implants and is kind of afraid to do that. They have PV. They know that the process is going to involve a lot of bleeding. And I mean, this is one of those questions that I think, ask away because it's good to find out if you're going to have any kind of oral surgery or any kind of surgery, you should include your hematologist in that process. So what would you say to this patient?
Well, I 100% agree with you, right? I mean, the diseases themselves by themselves are not a contraindication to people getting surgery for whatever reason. What has to be thought about carefully is the bleeding and clotting risk. We worry a little bit more about clotting, just because these diseases predispose our patients to clotting events, right? But not all surgeries carry the same risk. And it is absolutely vital that if somebody is going to have a surgical procedure, that they make sure that they link the surgical team to the hematologist and that they have a conversation, because we have a sense of things that are going to put people at higher risk of having clotting events, and those things tend to be abdominal surgeries that are extensive or orthopedic surgeries, whereas minor surgeries we don't worry about so much. So that's one part of it. But then there's the bleeding part of it, because so many of our patients are on aspirin or even on anticoagulants. And so there has to be a careful plan laid out before about how we're going to deal with the anticoagulation. Are we going to stop it 7 days before? When do we resume it? So the key thing, in my opinion, for anybody of our patients having surgeries are make sure that there is a conversation between the hematologist and the surgeon, and that there is a very clear plan about what is going to be done with, medications, anticoagulation, all of those things should be well spelled out before surgery.
Yes, absolutely. And so can ET cause bone lesions? An MRI has found a lot of bone lesions and a PET scan has ruled out bone cancer.
It can. And so there's different types of bone lesions. So there are, what we call lytic bone lesions, which are not typical of MPNs. That's we see with other diseases like myeloma and other types of things. And that's where we need to think there may be something else going on. But what is not so uncommon is that patients have an MRI and that there is an abnormal bone marrow signal detected by the MRI. In fact, I've actually seen a few patients who were referred to us because one patient I remember in particular was in a car accident, has no prior history of anything. They found abnormal bone marrow signal. That led to a workup that eventually led to a diagnosis of an MPN. That's not a common thing, but it can happen. So it is not unusual that an MRI will pick up bone marrow, what they call signal intensity changes, not
Mhm.
uncommon at all.
Oh, okay, interesting. So this person is asking the question actually about his wife and it wants to talk about or address the issue of weight gain on Jakafi. And his wife has gotten on a low carb ketogenic diet or ketogenic and is still Despite this, her daily blood glucose seldom drops below 90, and she never gets into a level of therapeutic ketosis. Is that due to having an MPN or the effects of Jakafi or just her metabolism?
Could be partly metabolism, but it can certainly be partly due to the Jakafi. Jakafi definitely causes weight gain in a proportion of patients, and there are distinct biochemical reasons for that. In the beginning we thought it was because patients have their spleen shrinking and they're able to eat more, but it actually goes beyond that. And if it is becoming problematic, then I think it's good to talk to the treating doctor about potentially modifying the dose. Sometimes that will help. And if that doesn't do the trick and continues to be a problem, that may be a reason to think about switching to a different therapy.
Okay. I haven't heard this before, but this person took Ojjaara for 9 days. Their platelets dropped to critical levels. They had a severe cough and sore throat plus hiccups that were full body racking. The dosage was 200 milligrams. It was suggested that he take a lower dose, but they are afraid to try the drug now. Does it actually slow the progression of MF?
Yeah, a couple of complicated things. I mean, certainly in the beginning with any JAK inhibitor can cause anemia and thrombocytopenia. Some of them do it to different degrees. And so what's being described in terms of platelets coming down with initial treatment can happen with any of these drugs. And often what we'll do is we'll either reduce the dose or we'll pause it. The other symptoms I'm not as familiar with, the hiccups and other things, but can people have sort of idiosyncratic reactions to a drug? They can, right? It is entirely possible. I think, there's two ways to think about this. One is that you could retry the drug at a lower dose with the expectation that there should be a less chance of a side effect if you go up slowly from maybe half the dose. That's not an unreasonable thing. But, of course, we are in an era where we have options. And so certainly, I think in this case, it is also reasonable to just try a different drug.
Mhm. We always hear about patients that have severe itching, and they're told to take a cool shower instead of a hot shower and stay out of the sun, or and protect yourself in the sun. But after all these years, I've been in this space forever, and is there any medication now available to our patients that actually diminishes the itching problem, or is there something they can take?
Yeah, no, I mean, and it's hard to I think relate to people who don't have the disease or deal with the disease, like what itching means, because itching does not mean what people who don't
Right.
just think of, right? And that's something that's hard to relate to people. But it depends. In my experience, Jakafi has actually been an excellent drug for itching in PV patients and even in non-PV patients who have terrible itching. That has been one of the best drugs for it, but I certainly have patients where it has not helped or hasn't made the difference. There are, a couple of other things that we do and sometimes help. Sometimes it is modifying how patients do things, right? So, for example, we tell people to take cooler showers, number one. Number two, we tell them not to, to pat themselves dry or air dry rather than to, towel off aggressively. Sometimes that helps. I always want to be careful about those things too, because we don't want to tell people, listen, you need to restrict and completely change your behavior, because sometimes that's a big burden. But some of these things can help. Antihistamines help to some degree. There are some antidepressants that can also be effective, with helping itching. And then there are, as it turns out, some of the powerful anti-nausea drugs that we use for people who are getting chemotherapy for solid tumor cancers. Some of those drugs actually can help with itching as well. It's a little bit tricky to get them covered because this is not an indication for them. It's really as an anti-nausea drug, but in patients with who've tried everything, we've actually found that works, and there is a published literature on that.
That's interesting, fascinating. I had something years ago that caused this amazing itching. I mean, I would touch my skin and it would but the itch was not on the skin. And that's what several patients have told me that's exactly what it feels like, which was awful.
Mhm.
And all right, this person has the other issue that comes up quite often is bone pain. And this individual has bone pain in their leg. They were diagnosed with ET 2 years ago. Is the bone pain a result of the ET? And I hear two camps on this. Some physicians say, oh no, and other physicians say, oh yes. You know, it seems to me, not a physician, but the number of patients that seem to have bone pain is pretty prevalent, you know. And I'd love to hear your answer to that.
Well, I'm definitely in the camp that it can absolutely be related. I've seen it too often. Um,
Yeah.
and you know, and there are some biological reasons that are plausible that can explain that. But yes, I think it is absolutely potentially a relatable thing. And here, there's a lot of different things that have worked for people. And so there are, for example, anti-inflammatories, NSAIDs, that can be helpful, but one has to be careful that if you're on an aspirin or you have other medical conditions that would prohibit you from taking them, and you don't want to use them long term if you don't need to, because they can harm the kidney function. But that is something that can help. Sometimes short bursts of steroids will help. Sometimes JAK inhibitors will help. And then sometimes medications that we use for neuropathy, drugs like gabapentin, can
Mhm.
also be helpful. And sometimes it's just a mixture of a cocktail of all of those things. So there are different things that can be tried for it, but I'm absolutely a believer that it is related.
Yeah, and the neuropathy is the other thing, even in individuals' hands, you know, where the hands, I know most people have it in their feet, I think.
Mhm.
That's what I always heard, but I've heard some patients complain about this feeling in their hands as well.
Mhm.
What is your opinion regarding switching from hydroxyurea to either Pegasys or Besremi due to the possibility of altering the course of the disease?
Okay. This is a very rich topic, and it's a
Hmm.
very interesting question, right? Well, you know, I think maybe the summary statement to begin with. I think there is an emerging literature that says to us, at least in PV, I would say, that that interferons can potentially modify the course of disease. So what supports that idea? Well, a couple of things. One is that there is a really nice paper from our friends at Weill Cornell. Guy Papazenia was the lead author of that. And they looked at their experience, I think, over the last 40 years. And they said, well, look, if we look at all the PV patients and we look at the patients who got interferon versus those who got hydroxyurea versus those who got phlebotomy, it turns out the patients who got interferon seem to have fared better in terms of their disease progressing. Now we have to be careful with data like that because it's retrospective and there's biases in that. In other words, patients who could get interferon may have just been healthier patients because they could
Hmm.
tolerate it versus those who could get hydroxyurea. So we always have to be careful with retrospective data, but that is at least one piece of evidence. Other pieces of evidence are that, the more recent studies with Besremi seem to suggest that you can decrease the amount of the JAK2 mutation, which does seem to correlate with people doing better, with having better outcomes. And there was very recent data published on that from the experience with Besremi. And then there was a randomized trial that was performed in younger patients with PV, who are not the ones we typically treat with the medication, but at least in those patients who got randomized to Besremi, there seemed to be a signal that they had a less likelihood of having events like blood clots, for example, than patients who were just getting phlebotomy. So the evidence is beginning to mount, right? Are we at a point where I think we can definitively declare that that is absolutely a better treatment and that it will modify the disease? No, I don't think we should do that yet, but I think there is certainly mounting evidence in that vein.
Hmm. We still know hundreds of patients that are on hydroxyurea that are doing fine and have been for a long time
Mhm.
and are, don't want to switch. And so, but this question of Besremi, so one of our patients asks, they have switched to Besremi and they're suffering from some depression. Will
Mhm.
that depression go away in time? Or should that be treated right away? What is your opinion?
Yeah, I think, we know the interferons can certainly cause or be related to depression, and we have to take that very seriously. I think that, we certainly any type of untreated depression is not a good thing. We need to address it. So the first thing is, yes, I think it absolutely should be addressed and assessed. Number two, does it tend to go away? It tends to get better, and sometimes when we have to take patients off of the drug, it does tend to go away or get better, right? So that, of course, begs the question, should somebody come off of therapy if they develop depression while on interferon? And that is where we really need the help of our professionals in mental health, because we really need to get an assessment of what do we think about this depression? Are there other things that are contributing to it? How severe or significant is it? And does it warrant therapy? And if it warrants therapy, does it get better? But this is the type of situation where we absolutely need consultation with our mental health professional
Mhm.
colleagues.
But if one was never depressed and then goes on Besremi and is depressed, it seems like that would be, and it is one of the side effects that we've read about. But yeah, definitely include a mental health professional if it's ongoing.
And I,
Um,
I think along those lines, right, for our patients who are on any interferon, we always make it our practice to talk about that and just say, how are you doing? Or, how have your moods been? And, if the patient has a spouse who comes with them, we often ask them the same question. I think part of our job as people giving this drug is to try to screen our patients for depressive symptoms as well.
mhm. That's great. Um, can you give examples of the stimulants that you found to help with fatigue?
Yeah, the oldest one is Ritalin, which was given primarily to children with hyperactivity, which I think it still is, but that has been used in low doses for patients with cancer-related fatigue. It has been well studied. It works well for some people. Some people find that it does give them that little extra boost of energy or that extra concentration. And for other patients, they say that it just makes them jittery. So we have professional supportive care professionals and our mental health colleagues who are much better versed in administering the medication. But that is sometimes a reason that we refer to them, is to think about Ritalin as a stimulant that
Mhm.
could be used here.
And it is successful with,
Mm.
oh, that's great. Have we talk about familial MPNs and we learned that a couple other gene mutations are kind of cropping up and showing their faces when it comes to familial studies in MPNs. Have you ever seen twins who both have an MPN?
Um,
Or do you know of any twins that?
Yes. So and this is actually this has been studied and published. So there are actually a couple of reports, including some really elegant genetic work in twins who both actually ended up with MPN. But I have seen cases of twins both with blood cancers that are somewhat related, not necessarily both MPNs. One has an MPN, the other has a somewhat related blood disorder. So there's a very clear inherited genetic component in some people's disease without question.
Mm-hmm. And again, there are two camps on that topic. Those that absolutely disagree that it's familial, and those that absolutely believe there is a familial link. And so it's kind of sad for the patients because sometimes they'll ask the question and get one answer, and then we can even provide some evidence that it's different, but it's interesting about the twins. There have been lots of studies with twins, and I haven't heard of one with MPNs, but we'll have to look at that.
Mhm.
Can you offer a comment on the recently published study ARES trial on the use of low-dose aspirin twice a day versus once a day for precision antiplatelet therapy in ET?
Yeah, I don't recall all the details of it, but there have been two studies. One was a biochemical study that looked at how aspirin works in terms of what it's supposed to do, inhibiting the function of platelets. So that study did definitely fall into the camp of supporting the idea that using it twice a day, low dose aspirin, not anything more than a baby aspirin twice a day, may be biochemically more effective when used twice a day. The second is that we found it to be highly effective in patients, particularly with the burning and tingling in their hands, what we call erythromelalgia. That seems to work actually well in a number of patients, giving them the aspirin twice a day. So I think it is an effective thing. And in terms of dosage, it's not a concern because, a baby aspirin twice a day, still at the total daily dose, doesn't come to a level where we would be too worried about bleeding events.
Mm-hmm. Boy, aspirin's something, isn't it?
It does wonders.
It does. I mean, one of our other webinars, the physician talked about how aspirin really was and is a wonder drug for so many things. And I just find that interesting. Now, we know that at the U of M, the University of Michigan, Dr. Pettit and others are, they were anyway, doing a clinical trial using MRI instead of bone marrow biopsies. Do you think that's a possibility in the near future that most places will start to do that?
This is a really interesting question because we've been looking and asking the same question. Could you learn what you need to learn from an MRI? And there is actually a literature on this. It's 20 years old, but nonetheless, there is a literature on using MRIs to, for example, identify the amount of cellularity in the bone marrow, which is one of the things we assess when we do a bone marrow biopsy, as well as potentially the amount of fibrosis. Can it at this point give you, the details in terms of how many abnormal cells there are, how many what we would say blast cells, which are early form cells are? Not that I'm aware of right now, but at least as a way to gauge the amount of fibrosis, there is actually some established literature here. So I think that is a route we should go down. And we have to ask the question, could we do a lot of what we need to do from both testing in the blood for things like genetics, as well as using things like MRI to tell us more about the fibrosis, instead of doing an invasive procedure on patients? Yes, we should put effort into that.
This question came up. Actually, we got one of our physicians was talking about how he palpates the spleen every single time a patient comes in. And then we were bombarded with questions or with comments from other patients that said, mine never does. And so my question to you, there's a turkey standing at my window, a pre holiday turkey. He doesn't know it yet, but anyway, is that something that you always do with your patients, is palpate? I mean, many don't. It's surprising.
Well, in New York City, we don't have a problem of turkeys appearing in our windows. Other wildlife, yes, but let's not go there. So I think it is important, right, in the sense that gives us a gauge of where things are, right? In as much as we look at the blood counts, we talk to the patients about how they feel. To me, this is another marker. Why is it important? Well, patients may not always have a new symptom related to spleen, but what is important is if we're noticing on the exam that, well, you know what, things are gradually getting bigger, that has to raise our antenna and say, look, something's going on. Something is changing with someone's disease. It's a very simple way to, assess that, right? In many cases, things are stable, and there are certainly caveats with doing the spleen exam. If, for example, I see a patient and the next time my nurse practitioner sees the patient, we come up with slightly different values, right? Which is okay. That's what I expect. But if things are grossly changing, we're both going to figure that out, no matter who's doing the exam. So I think, to me, in as much as we use things like the blood test, this is another way for us to assess what's going on with the disease.
Absolutely. I'm so glad you said that, because it just seems to me that it would be standard practice, and somebody just applauded that. This person says, my hematologist will order a phlebotomy if my hematocrit or my hemoglobin is elevated, but not if only the red blood count is elevated. What are your thoughts?
So in standard practice, we use the hematocrit as the guidepost for when to do a phlebotomy. The red count can be elevated, but it isn't is a standardized measure used in practice in most places to decide on phlebotomy. And the same thing is true of hemoglobin. Now, there is fundamentally, there should be a relationship between the hemoglobin and the hematocrit. But as it turns out, we don't actually measure hematocrit in most places. What we're doing is we're deriving the hematocrit value based on other variables, which include the red count and the size of the red blood cells. So it's actually mathematically derived. It's not directly measured. But either way, all of the trials that we have done have used the hematocrit as the marker for when to intervene or not to intervene. So the hematocrit is what we tend to use.
Okay. So we were talking about night sweats earlier, and this woman who's 60 years old, who had a hysterectomy at 50 years old, has been on hydroxyurea for 18 months, but the last 6 months has had terrible night sweats. Is there a correlation between the use of HU and night sweats?
Yeah, that's interesting because I think
Yeah.
I've seen that happen before. In general, the answer would be no. Most patients, I don't see that they develop night sweats when they go on hydroxyurea, but it's I've seen this as a paradoxical effect of not just hydrea, but other medications, sometimes even JAK inhibitors that for whatever reason, the night sweats get worse. And I don't know why that is. I can speculate, which my speculation has always been that, there's some degree of cell death from the hydroxyurea, and that's what's causing the night sweats. But there are definitely other potential explanations, but I've heard that, but it's infrequent.
Hmm. We know that the eyes can certainly be affected by an MPN, and are bloodshot eyes a symptom of ET, or could it be from the hydrea?
It could be from the hydrea. That is certainly a possibility. Bloodshot eyes we tend to see more with PV. Sometimes that's actually when people present for the first time, they look very red. They can have bloodshot eyes. So that can be from the disease, just from having dilation of vessels in the eyes. But hydrea could certainly do that too.
Could advances in gene technology reduce or eliminate the JAK2 modification?
I mean, this is the holy grail, right? And
Yeah.
it's it's an area and it's a subject that people are definitely looking into. It's complicated. I think, at least based on the technologies we have right now, it would sort of like be doing a stem cell transplant in that you would have to take somebody's cells, you would have to genetically modify them, and then put them back into the patient, what we would call an autologous transplant. Um, could that work? Well, that would be based on the notion that you can edit 100% of the mutated cells. And even right now, with the best technologies that we have, you can't do that. But could you reduce the amount of the mutation to the extent that it's not actually causing any disease symptoms or abnormal counts? That to me is a plausible thing. We have to be careful because there are concerns about genetic manipulation causing other malignancies. This happened early on when these types of studies were being done. And there is concern even with some of the newer technologies like CAR T cells, which we're using for diseases like myeloma, that they may be leading to other malignancies. So I think that's the thing that we have to be very, very careful about as we think about this, is that there is always the potential to do more harm here.
Yes. Speaking of familial MPNs, are there any genetic tests that can be done for the patients, who are in a family that they want to see if their child or their family member has JAK2 gene mutation or CALR or something? I don't know that there are any specific tests, but are you aware of any?
Yeah, so there's a couple of things. One is in cases where we suspect there may be an inherited predisposition, or we have a patient who is young, i.e. they're in their 20s and have an MPN, which is unusual, but we do see it. We can do what's called germline testing. So let me explain what that means. Germline testing is testing of the inherited component of the DNA. Whereas when we just simply take somebody's blood and test the blood, what we're doing is what's called somatic gene mutation. So somatic genes are the genes that one possesses. Germline refers to things that you inherited. And so there are actually ways to test for things and determine if they are germline. So one example of how we do this is that we can consent patients and take their blood, and then we also clip their fingernails, and we look to see, is a DNA change that we find, for example, the JAK2 mutation, is it present both in the blood and in the fingernails? Because the fingernails really should represent DNA that is germline, i.e. that is DNA that one is born with and inherited, and should not necessarily, will have some mutations, but it shouldn't have pathologic mutations. And so if we find a mutation that's also in the nails, that says to us, wait a minute, this is potentially an inherited mutation. So that's one way to test for it. Sometimes we can tell by what's called the VAF. People talk about, how much of the JAK mutation there is. So that's called the variant allele fraction, and it gives you the percentage of the JAK2 mutation. And for inherited mutations, oftentimes that number will be 50%. So if we see somebody who has 50% JAK2 mutation, that would also kind of raise our eyebrows and say, this could be an inherited mutation. Those tests aside, in any case where we have a suspicion, when would we have a suspicion? Well, if we see a patient, let's say a younger patient, and they have, or well, not necessarily even a younger patient, a patient who has any first-degree family members who have an MPN, that should raise our suspicion. Or if we see somebody who has first-degree relatives with other blood cancers, that should raise our suspicion that there's something inherited going on. And in those cases, we refer patients to genetic counselors. And these are people who their whole training is identifying the risk of a particular mutation or disease being inherited, but they can also do more specialized genetic testing. So yeah, so these things often can be tested for.
That's great. This is a quick question, but it warrants some attention, and that is, how will the current disasters in North Carolina and Florida impact research and patient care at MPN centers? I can tell you that you can probably do video, appointments with your physicians. If there's an emergency, I'm not sure. I know that the airport in Nashville is still closed, and I know that the Florida, the entire state is probably not in good shape right now. But any other thoughts?
Yeah, I mean, there's a
Subject?
couple of things that people should always think about, right? One is if you're on a medication, particularly something like Jakafi, it is critical, if possible, to make sure you have enough drug supply to get you through for a period of time. And if you don't, to try to reach your physician's office, because there are things that can be done to bridge people through if they, fall off their medication. So I think that's a critical thing. For most patients who are in the chronic phase of their disease and have the counts that have been stable, or on things like hydroxyurea and their counts have been stable, even if they went off of their hydroxyurea, nothing probably drastic will happen in 2 or 3 weeks. But there are patients whose blood counts, particularly, let's say, who have myelofibrosis, and maybe their counts are starting to decline, where they need to have access to more frequent counts. As a last resort, there's always the emergency room, but I don't think that's always the most useful, practical thing. So I think video visits as much as possible, to get through this period of time. I'm sure that people's healthcare teams can often provide them with prescriptions to get their blood checked in a place. Let's say they, relocated to another location to get away from the hurricane. Those are things that can be done, fortunately, in the era of telemedicine. So we do have ways to deal with this now.
Yeah, it's a great question, really, because even getting things, shipped is impossible when roads are blocked and flooded and so on. So, I'm glad that question came up. What are your thoughts on Inrebic and its side effects on the heart?
Inrebic side effects on the heart. I'm not
I really
aware,
haven't heard that.
of it having any particular cardiac side effects. I mean, it's an effective drug. It certainly can cause gastrointestinal side effects that one has to monitor for and treat aggressively, but that is a doable thing. And also, it is linked to something called Wernicke's encephalopathy, which is due to a vitamin deficiency, but that can also be prevented. But I'm not personally aware of cardiac events with the drug.
I'm not either. So this person has multiple non-driver mutations besides a high JAK2 VAF. What is your opinion on taking HU only since it does not decrease JAK2 in the bone marrow? Would a change of treatment be warranted?
I think it's an important question and a challenging question, because I think, it's absolutely correct. HU doesn't really do anything to change the mutation landscape. And in fact, there is some data that it might cause some changes in the chromosomes, that there may be more chromosome abnormalities in treating HU. Most of those may not be of any consequence, but some could be. It comes to the question of, do we give people treatments with the idea that we can change the genetics of their disease? There's very limited data that any of the drugs that we have can do that right now. We can reduce the driver mutation with things like interferons and to some extent actually with the JAK inhibitors, but they don't drive them away. They don't eliminate them. And the only thing that can do that is a stem cell transplant. So I think what we have to think about it, in a case like this where there are complicated genetics, is to understand, do we think that this is a risk for the disease progressing, right? In that there is data about this in PV and ET, but much more in myelofibrosis. And if it is, does that warrant thinking about a stem cell transplant or even, going on a clinical trial? I'm not saying any of those are the right decision. I think that's just the right question to ask. It may be that, in somebody who's getting clinical benefit from hydroxyurea and their counts are fine and they feel fine, that we don't concern ourselves so much about it, even though we know it's there in the background, knowing that there really isn't anything beyond a transplant that we can effectively do to change that at the moment.
Mhm. So when a new patient comes to you, these days, as we talked about, we have 4 different drugs now available that are, mostly JAK inhibitors. But are you more apt to what are you more apt to prescribe if the patient is symptomatic?
Right. And I think to me, it always comes back to the question of what are you trying to achieve, right? And, there are patients who come in who absolutely don't need any treatment. And the right thing to do is to put our hands in our pockets and just keep an eye on them, right? I think that is, in many cases, the absolute right thing to do. But there is a role for medications, and it depends. If we're trying to shrink the spleen or we're trying to alleviate symptoms, JAK inhibitors are definitely our drug of choice. And the choice of what drug to use is becoming more challenging, which is a good thing, because that means we need to think more carefully about what the drugs do and how they benefit people. For most patients where we're trying to reduce the spleen, any of them could be used effectively. For people who I think have a high symptom burden, I would say that, Jakafi certainly has shown itself both in clinical trials, but also just in clinical practice to be a highly effective drug to help us reduce symptoms. The other drugs can help symptoms as well, too. So it's not as if, other drugs can't do that. The other drugs, I think, maybe a little bit more, we use them in a little bit more of a selective manner. Those things like pacritinib we use with people with low platelet counts, things like momelotinib we use in patients who maybe have a more profound anemia. So there's a niche for each of these drugs. And I think that's always the first question is, what are you trying to achieve? And then how do you best achieve it? But now having, for drugs, we're in a better position to I think more selectively put patients on medication that's going to benefit them.
Mhm. How influential, I think I know the answer to this, but how influential are life stressors on ET platelets?
I get that question a lot, right? And I don't know of any clear evidence. On the other hand, can inflammatory conditions make platelets higher? Yeah, they absolutely can, right? So is it plausible that, if somebody's under stress that causes physiologic changes that it could result in the platelets go higher? I think it is, it's not plausible. I think it is, but on a day-to-day basis, I'm not so sure how much of an effect it would have.
Yeah. I mean, stress in any form can cause issues, health-wise. So, um, is it possible for PV to not progress? And anecdotally, I knew a gentleman when I met him 22 years ago. He was in his 70s. He had PV forever. And I don't think he was taking anything at that time, but I think later he did, but it never progressed. He died when he was in his 90s. And so that's just my one little story, but what are your
But I
thoughts?
think that's illustrative, right? Let me put it this way. Is it inevitable that PV will progress? The answer is absolutely not. It is not inevitable. No. I think what we have to do a better job of is trying to figure out who are the patients who are going to progress, right? If you kind of look at the data, which has a lot of flaws in it, but the common thing we quote people is saying, well, at 15 years, maybe 8 to 10% of people with PV will progress, which I'm not sure I would put that much stock into that number. But even if that's the case, our job right now really needs to be figuring out who are those 10%, because we may want to treat those patients very differently than the 90% who aren't going to progress. So again, to reiterate, it is not inevitable. We've got to, put effort into figuring out who are the people who are at risk for progression.
Right. That is so, I mean, that's the topic of the day, isn't it? Let's try to figure out who those individuals are and find some solutions as quickly as possible.
And
Um,
along those lines, it's important for people to know this
yeah.
is absolutely an area of focus. The MPN Research Foundation is putting resources and effort into this
Mhm.
within the community. A lot of us are working on this and thinking about this. So it's important for people to know this is absolutely an area of focus.
Right. And at the women's conference, uh, one of our speakers, actually, that was her topic about progression. And so you can view that on our website, or on our YouTube website also. When you have a bone marrow biopsy, and I can tell this person, it's so easy for us to just talk about these things and not realize that many patients don't really understand how the bone marrow works and where it is and how you determine this information. And this question is a perfect example, and I'm so glad they asked. When you have a bone marrow biopsy, is the result for that area of the bone marrow, or is it the bone marrow the same throughout your whole body?
That's a great question.
Yeah.
The answer is unclear. So for some diseases, years ago, meaning more than 10 years ago, they used to do bilateral bone marrow biopsies, right, to get a better sense of sampling. I think there is definitely heterogeneity within the marrow. And sometimes we see this because we'll do a bone marrow on a patient, successively within 2 weeks, not necessarily a patient with MPN, but let's say leukemia, and we see different things. So I think that there is heterogeneity there, and we are kind of taking it, when we take a sample, to be representative of the broader bone marrow. Does it mean it is exactly the same throughout? I think the answer is probably no.
Mhm.
But I think that it is at least to some degree representative.
Okay. Is when a patient is prescribed 2 baby aspirin a day,
Mhm.
would you say take both of those at the same time, or take one in the morning and one in the evening? What do you recommend?
I think, you could do either. There is, as we were talking about earlier, there is data to support the idea that you could take it twice a day safely, right? And especially for patients who have the burning, tingling symptoms, I think twice a day is the best way to go. It tends to help better. But there is nothing wrong with taking both of those as one dose per day. It's still
Okay.
a safe dose.
And this question is about the eyes again. Is there any research to show that hydroxyurea can cause dry eyes to the extent that it results in corneal scarring?
That's interesting.
Yeah.
Um, I'm not aware that there is, at least not off the top of my head, but hydroxyurea can cause a number of changes to the skin. Sometimes even people will complain of dry mouth. So it isn't inconceivable, but I don't know the actual data with regard to that question.
What does it mean to have recurring and gradually increasing immature granulocytes in MPNs? And what level starts to become concerning?
It depends on what the immature granulocytes are. By themselves, they're not necessarily a concern. What we look for earlier white blood cell types, so these are things that are called myelocytes or metamyelocytes or blasts. These are all things that are part of the normal development of blood cells, but those are cells that we should only see in the bone marrow in an individual, not in their blood. With people with myelofibrosis and sometimes with PV, we'll see them in the blood. We tend to think of those things for the most part as a binary thing. Either they're there or they're not there. For blasts, it's different because the number of the blast cells in the blood does matter in terms of how we think about prognosis or how we think about what's going on with the disease. But for the other types of cells, in most cases, it's more of a binary way of thinking about it.
Okay. This person would like to know how high the platelets need to rise before becoming dangerous.
It's a complicated question because as it turns out, there isn't really any data that links platelet count with the risk of thrombosis. In other words, one would intuitively think that as the platelet count goes up, the risk of clotting goes up. But that actually doesn't turn out to be well supported by data. What can happen and what the danger is that as the platelet count gets high enough, bleeding can happen. And the reason is that you have clotting factors in the blood, and they bind to platelets, and then those things bind to the site of an injury. If you have too many platelets, what can happen is that they absorb the clotting factors. And so when you need the clotting factors, when you have an injury, they aren't there anymore because they're all tied up with platelets. So there's nothing to stick to for the remaining platelets. And that is something that's called acquired von Willebrand deficiency. We see that, or you can see that when the platelets get to about 900,000 or higher. So typically we test that in all of our patients when their platelets get to that level. But if patients are saying to us, you know what, my gums are oozing even when I'm not flossing, or I'm having nosebleeds, or I'm having bruises, then we need to check for it.
And so, what would you say to a new patient, a young patient, who is not doing so well on a drug and realizes that, this is a chronic blood cancer and they're 23? And, what would you say to them in terms of what they can expect, and what can you enlighten them, or not enlighten, but what would you say to encourage them these days? Because, I can say, oh, we've got 4 new drugs and we have all these drugs in the pipeline and we have these wonderful people, including you, doing excellent MPN research. And from your mouth, from your perspective.
It's important. I have a sizable number of patients under the age of 40, right? And what it always occurs to me is that you have to think about those patients in that age group very different than the people who are diagnosed in their 70s, because it's going to potentially impact important milestones in their life, like having kids or other important milestones in their life, and they have to live with it. And there has to be a way that they have to live with that, which is different at that stage of life versus later stages of life. So it's a complicated thing. I think that we need to do a couple of things, right? One is we've got to help patients at that age figure out, how do you live with the diagnosis? Because we don't want this to become the center of their entire existence, which is, if someone who's really symptomatic, that's an easy thing to say, but a hard thing to do. But for other patients, there is a real adjustment period, and they have to rethink how they live their lives, and they've got to figure out, how do you add this to your life and not let this become your life? That takes a lot of work, and that really often involves us getting other professionals to help us with that. But that's important because that comes into quality of life.
Mm-hmm.
From the sort of broader and longer term perspective, what I always say to our patients, particularly our younger patients, is that there's been more progress made in the last 5 years than there has been in the last 15 years. And that is only going to accelerate. There's no question. There's so many drugs and treatments that are already in trials for rare diseases. These are rare diseases. And that's an encouraging thing. We're going to learn things. We're hopefully going to change how we treat the diseases in the near term. I'm a believer in that. I don't think those are just empty promises. And that is all because there has been, 20 plus years of excellent work on the biology of the diseases. That's where these ideas have come from. And as our technology is advancing, as somebody who also spends time in the lab, I see this. I see the new things that we're doing in the lab and how we're asking questions about these diseases that are fundamental to how they work. But that also means that that's going to get leveraged. And let me say that again, it's going to get leveraged into new therapies. I'm confident of that. So it's important for our patients to have that perspective that things have changed dramatically and they will change even more dramatically in the next few years. I have no doubt about that.
Well, that was going to be my last question. And you kind of answered it right there. And you were speaking more to the younger generation of MPN patients, but I think it holds true for everybody, and for all patients. Are you seeing any similarities in the lab with a younger MPN patients? Are seeing similarities in younger patients that is sparking an interest in more trials or more research in younger patients?
Yeah, and I think the questions being asked by some people who are focused in this area, like I think about my good friend well, Nicole Kashin at Cornell, right, who's focusing on pediatric MPN, right, and asking the question, how similar or dissimilar is that to the older patients? And we have to ask those questions now because it's important as we think about where we're going with therapies in the future to be able to reasonably say, look, things that are working in people who are in their 20s, 30s, or 70s should work in even younger patients, but we have to understand the diseases a little bit better. So that is an area that's being investigated, but that's an important question.
Yeah. So finally, what wisdom would you impart to the folks that will be watching this webinar or that are here with us right now, for the future? We'll see you at ASH, and there's lots going on at ASH.
For sure, right? A couple of key things, right? Remember, and now I'm being repetitive, but I'm being repetitive because I think these things are true. You are your best advocate as a patient. The fact that you are here at a webinar getting more information is really important. You should continue to do that, and you should continue to explore the avenues of information that are available, making sure that these are well credentialed, things like MPN Advocacy, things like the MPN Research Foundation. It's important to keep up to date. It's important because in some cases you have to keep your doctor up to date. Not everybody has access to a referral center, and it is a reasonable thing for you to bring up ideas and topics to your physician and say, listen, I've heard about this. Is this something for me? Should I know more about this? Should I see a specialist about this? That's really important. Owning, taking ownership of the disease and being a information junkie, that's vital. So that to me is the first thing. And the second thing is I go back to maybe what I was saying a few minutes ago, right? There is a rapid increase in progress that's being made. I've never been more optimistic. I think things are going to change fundamentally in the next 3 to 5 years. And people should hold on to that as hope. And remember that this is something that I try to say or to impart to most of our patients is that this is not a race of you against time. This is a race of development against time. And right now, development is going at a perhaps faster than expected rate. And that is a great thing for everybody. So there is reason to be optimistic. Absolutely.
Fabulous. What a nice way to end this program. And thank you so much, Dr. Rampal. You're a pal and a great physician, and so glad you could join us today. Thank you.
It is always my pleasure.
All right. We'll talk soon. And to all of those with us, we will be in touch to let you know when our next webinar is. And this is recorded, so you can review it again if you need to. Thank you.